It's a holiday in Calicut, I guess, tomorrow also.
Oh, tomorrow also declared.
I don't know. I mean, my daughter is always checking the Facebook of the collector. Hoping that,
Everyone does the same these days. I think like maximum search
yeah.
are that of Trishul district collector.
Hmm.
Okay, there are around 53 participants. I think we can go live.
Yes, sir.
Let me just start recording it. Okay, good evening. Welcome to this session of ISG PG Masterclass. We are having a series of recent advances. Last week we had recent advances in hepatology. This week it is recent advances in gastroenterology, and next week it is recent advances in the endoscopy. To cover the topic of recent advances in gastroenterology, we have none other than Dr. Sojan George, who did a splendid job last year as well. Okay, I know it's a very difficult task to comb through all these journal articles which have been published in the last few months, and then have a topic which is limited to 1.5 hours. But I think Sojan would have done a great job. I'm sure he would have done a great job in collecting all the best and recent articles in the gastroenterology, and that will be presented to you this evening. Dr. Sojan is an associate professor and senior consultant at Amala Institute of Medical Sciences, and he has a bright academic career and a good clinical excellent doctor. And today's session is chaired by our beloved Dr. Binoy Sebastian, who has been always associated with the PG clinics. He's a senior consultant at Medical Trust Hospital, Kochi. And along with me, Professor Jayanti ma'am is likely to join the session as a moderator. And without further delay, we'll start the session. Over to Dr. Binoy.
Yeah, thank you, sir. Good evening, dear friends. Without wasting any time, I think we'll straight away proceed to listen to Dr. Sojan. Thanks, Dr. Sojan, for all this effort. It's not easy. Presenting one single topic and collecting references related to that particular topic would be easy, much easy. But picking from here and there and assimilating everything together as a capsule is going to be extremely useful to all these, not only to the postgraduates but to the faculty as well. Over to you, Sojan.
Thank you, Vinay, for this, and Varghese sir for those kind words of introduction. At the outset, let me thank Professor Dr. Varghese Thomas sir for giving me this opportunity. It's actually very demanding, but I love the exercise of revisiting my PG days, going through all the recent journals, making a capsule out of it and presenting it in the best possible way in front of such an allied audience. Especially if it benefits someone, I think I would be really grateful. What I have done, I know that this is the second session after an excellent session by AB last week. I'll be dealing today with what is new in gastroenterology. So what I've done is I have gone through the last 1.5 to 2 years of journals, which includes American Journal of Gastroenterology, Lancet, NEJM, Indian Journal of Gastroenterology, a bit of PubMed search. It was actually really, it was really worth, the time was really worth spending, and I think I am the one who was most benefited out of this exercise. So without any further delay, let me move on to the first session, first topic. As the fear of COVID goes off and we were all taken by a storm over the last few years by COVID, but the same trend is seen in journals as well. Now, there are very few COVID-related articles in journal, and IBD again has come to the center stage. So I'll be starting with IBD today. I'll be discussing what is new in IBD. For the easy remembrance, I made it into 4 parts. First is regarding the pathophysiology, what has changed or what are the recent articles. Then investigations in IBD, some of the new treatment options and their related data, and complications of IBD. Over the last few months, there have been some debates going on as to whether routine anti-helminth exposure to children As we all know, we are all aware of the hypothesis, that is a hygiene hypothesis, and whether routine exposure to antihelminthics would make somebody prone to IBD. So this beautiful article published by Mansi Agarwal from Denmark actually looked at this fact. So they studied the data of close to or over 15 lakh individuals, of which more than 6 lakh individuals had childhood or adolescence mebendazole exposure. 1,555 of them went on to develop pediatric IBD, and 1,499 went on to develop adult IBD. So what they did was that they tried to analyze the hazard ratio for development of IBD in patients who had an early mebendazole exposure. Now, when they studied people who have an exposure less than 18 years, it was found that the hazard ratio was not high. So there was no increased risk of IBD in people who were exposed to mebendazole less than 18 years. But then they did a subgroup analysis and they looked at children less than 5 years who were exposed to mebendazole. And it was found that the hazard ratio for adult onset ulcerative colitis in this group was significantly higher, amounting to 1.32. And they came to a postulate that early life, very early in life, if somebody is exposed to mebendazole, that is less than 5 years, they have an increased risk of development of adult onset ulcerative colitis, a point to ponder on. Now, regarding investigations in IBD, what has changed? I think like one topic of interest over the last few months has been intestinal and ultrasound. And I think like it is especially important for the exam going PGs to take a note of this commentary, which was published in Gastroenterology regarding intestinal ultrasound. So if you look at the indications of intestinal ultrasound in a patient with IBD, it happens in every stage. It helps us to differentiate between IBS and IBD. It helps us to identify the disease activity. It helps us to assess the treatment response and to decide on whether to escalate or de-escalate the treatment based on transmural healing. Now, it also helps us to prognosticate and assess for complications, and also helps in postoperative recurrence. So it is helpful in diagnosis, staging, disease activity, prognostication, follow-up, and prediction of outcome. Now, how is this done? It is done using two probes. You need a convex probe, which is a low frequency probe with a frequency of 1 to 6 megahertz, and it helps in a panoramic view of the whole abdomen. But a more specific probe, a linear or a microconvex probe, is also needed, which uses a higher frequency of 5 to 13 megahertz, and this helps to look into the various bowel layers. Now, as we all know, muscle seems darker in ultrasound and fat seems whiter. So the layers which contain the muscle, that is muscularis mucosa and the muscularis propria, would look hypoechoic in an intestinal ultrasound, while the other three, that is the superficial mucosa, the lamina propria, and the serosa, all would look whiter. So there will be a 5-layered appearance of bowel in the intestinal ultrasound. Examination should start in the left iliac fossa, identified the sigmoid colon, which is identified using the landmarks of left iliac artery and vein and the psoas muscle. It should proceed throughout the whole colon and end by examining the colon in the right side at the ileocecal junction, which is identified by the landmarks of right iliac artery and vein and psoas muscle. Then it is scanning through the whole abdomen, just like you are moving a lone mover, both in horizontal and vertical direction. So that is the technique. What all things do you assess in intestinal ultrasound? You look at the thickness, look for Doppler signals, stratification, and fibrofatty proliferation. So these are the 4 things that you looked at. If somebody has normal thickness and normal Doppler signals, that is what you call as simplified transmural healing. If in addition to the first 2, they have either one of the third or the fourth, it is extended total healing, transmural healing. And if it is complete, you will have normalization of all these 4 parameters. So you look at thickness, Doppler signals, stratification, and fibrofatty proliferation. You could end a short note on intestinal ultrasound by the advantages, which can easily be remembered by the mnemonic A, B, C, D, E, S. It has got a higher acceptance because it is non-invasive and convenient. It is a bedside test usually done by the treating physician because of a lesser learning curve and wide availability. C stands for cost effectiveness, and hence it is repeatable. D, it helps in decision making because the best target right now is considered to be transmural healing. E stands for equal efficacy. Studies have shown that the efficacy is as equal to CT or MR angiography. And since it doesn't utilize ionizing radiation or contrast, the side effects are minimal. Now, there was a interesting molecule which has come up recently, that is the serum leucine-rich alpha-2 glycoprotein, which is a novel biomarker for transmural inflammation. As I've been telling, transmural healing is thought to be the best treatment target as per the treat-to-target approach, and that is the latest one as well. Now, how can we detect a transmural healing? We have CT angiography or MR angiography or intestinal ultrasound. But some of these are cumbersome and the patient has to come to a doctor. It may be costly as well. So they were looking at serum markers to identify transmural healing. The most commonly available ones are CRP, but the results have been inconsistent in most of the trials which have been conducted till now, and fecal calprotectin, but it is a bit cumbersome to collect. Now, leucine-rich alpha-2 glycoprotein or LRG is stimulated by IL-6 and TNF-alpha, IL-1 beta, and IL-22, unlike CRP, which is stimulated only by IL-6. And hence, it could be a better marker for transmural inflammation in Crohn's disease. The only flip side is that it may be elevated in other conditions like periodontitis, asthma, infections, and rheumatoid arthritis. So this paper, published by Takanaka et al. In June 23, American Journal of Gastroenterology, showed that LRG levels were significantly higher in patients who had transmural inflammation, and the value and the sensitivity was 67% and specificity was 90% when compared to MR angiography. Now, this paper further looked at how does it fare compared to the routinely used modalities like Crohn's disease activity index and CRP, and it was found that the sensitivity and specificity was significantly higher when compared to the MR angiography score compared to Crohn's disease activity index and CRP, and hence could be a marker for the future to identify transmural healing. Now, we all know about the scores. This is a third part of the that is the treatment of IBD. We all know about the scores which are utilized to predict steroid response in acute severe ulcerative colitis. We have the commonly used Oxford criteria, the Ho or the Scottish index, or the Lindgren score. All India Institute of Medical Sciences, Saurabh Kedia, Vinudha Ahuja et al. Came out with an AIMS index, and this has two parameters: a baseline UC ulcerative colitis endoscopic index of severity more than or equal to 7, and a day 3 fecal calprotectin more than 1000. Each of these is given a score of 1, and if the score is more than or 2 out of 2, then it indicates that this patient has a 100% chance of failure of steroids. On the other hand, if the score is 0, it rules out steroid failure. And AIMS index in this study was found to be better than the Oxford criteria as far as specificity and positive predictive value was concerned. So this was an interesting article which has come up recently in Indian Journal of Gastroenterology, 2022. Now, the commonly asked question as far as IBD treatment is concerned is, how do you differentiate between biologics or small molecule? As we all know, biologicals are anti-TNFs, vedolizumab, ustekinumab, and the group. So the group of monoclonal antibodies, and the small molecules include steroids, azathioprine, tofacitinib, and the like. So in this table, which has been adapted from American Journal of Gastroenterology, I have listed the differences between small molecules and biologics. Biologics, as we all know, are proteins, while small molecules are synthetic chemicals. The route of administration is most often parenteral. I say most often because research is going on to develop oral anti-TNF alpha right now and has met with some success, while small molecules are almost always oral almost always have a oral route of administration. The structure can be variable among various biosimilars. So you have a central chain which is almost similar, but the side chains or the glycosylation may be different because they are produced by different cell lines. While in a case of a small molecule, the structure is always fixed. Degradation is by catabolism in biologic, while it is by metabolism in small molecule. Mechanism of action is usually by blocking an antibody or a receptor or a depletion of a receptor in case of a biologic, while in a small molecule, it is almost always enzyme inhibition. As we all know, the cost is the main prohibitory factor in using a biologic, while the small molecules are cheaper. Being a protein, it always is associated with high immunogenicity, while the immunogenicity or development of autoantibodies is much more less likely in patients who are on small molecules. And there is something called as a stop-start use. You can use it whenever it is needed, stop it, and use it again without much problems and attain the same level of efficacy. This is true as far as small molecules are concerned, but when you restart a biological, you may face that the efficacy is lesser than what it was initially. So this table in general summarizes the difference between biologics and small molecules. So what is new are basically some of the molecules which are described in this figure. As we all know, the trigger point is the transmigration of bacteria from the lumen into the lamina propria, where it is ingested by a macrophage and is exposed to a T cell, and thus starts the inflammatory response. And as we all know, T cells are usually stimulated by interleukin 12 or interleukin 23, and this set of molecules, that is ustekinumab, bryakunumab, risankizumab, brazikumab. I seriously pray that these molecules had a simpler names because it seems a bit funny and very difficult to remember. But these are the molecules that have come up recently. The other molecules which were given in this group, that is infliximab, adalimumab, certolizumab, and golimumab, are all very familiar to each and every one of you. So I will not be discussing all those details. Then, whenever there is an inflammatory cascade, more and more T cells are recruited to that site. And this happens because the endothelium gets stimulated and expresses an adhesion molecule to which the alpha 4 beta 7 receptor of the T cell binds. And this results in translocation of the lymphocyte into the lamina propria, further worsening the inflammation. Some of these lymphocytes can also bind to the mucosal E-cadherin using alpha E beta 7 receptor, and this also can worsen the inflammation. So the new molecules of interest are basically IL-12-23 or IL-23 antagonists, the alpha 4 beta 7 or the beta 7 antagonists, and the anti-MADCAM molecules. So we'll see what data is available right now. Vedolizumab has been frequently in use right now and is no longer a novel molecule because most of us have been using it. As we all know, it is a humanized IgG1 monoclonal antibody against integrin alpha 4 beta 7. The advantage is that it is gut specific, so very little side effects. It is given as a fixed dose infusion, just like infliximab. So 0, 2, 6, and every 8 weeks thereafter. It is useful for induction and maintenance of both ulcerative colitis and Crohn's disease, but is the first-line biologic in UC, especially in the elderly or people with comorbidities because of its excellent safety profile. But the disadvantage is that it has a slow onset of action and hence may not be very useful in very severe disease. Ustekinumab, which is the other kit which has come up recently, it is an IgG antibody developed to bind P40 protein subunit found in cytokines of IL-12 and 23. It is approved for the treatment of Crohn's disease and UC. It is given as an initial IV infusion, which is weight dependent, followed by fixed dose subcutaneous injections. And the benefit is mainly due to IL-23 inhibition, which blocks the Th17 response rather than IL-12 blockade. So with this background and this slide, I would like you to remember the landmark trials which have proved the efficacy of all the molecules which have been in use right now. So since you are all familiar with the older molecules, just remember these names. That is, a vedolizumab was proven in Gemini 1 and 2 trials, and ustekinumab was in Unity 1, 2, and IM, which was a maintenance trial, and Unify was a trial of ustekinumab for Crohn's disease. Now, there have been a few head-to-head comparison trials, which was a rarity till recently. And the first one was the Varsity trial. This looked at the head-to-head comparison of vedolizumab versus adalimumab in patients who were either naive or already experienced an anti-TNF other than adalimumab. So this study showed that the results favored vedolizumab as far as the clinical response is concerned, the endoscopic response is concerned. The only place where adalimumab had an advantage was a steroid-free remission, which was significantly, or which was not statistically different, but the numbers were more favoring adalimumab. The second of this group of trials was the CView trial. This trial had a comparison between ustekinumab and adalimumab. But in this trial, it was shown that both were found to be equally effective. So this is in general regarding the trials in IBD. There are a multitude of trials, but I think like these are the ones which were the most significant ones, and hence you should at least remember the names of these trials. Recently, there was another study which looked at the efficacy comparison between ustekinumab and vedolizumab. So you have a patient who was on anti-TNF, failed, comes back to you, and you are confused which one to start. Is it ustekinumab? Is it vedolizumab? And this trial, published in the American Journal of Gastroenterology by Onali S. et al., showed that both were equally effective. So you can go by other factors like the age of the patient, comorbidities, and cost while deciding which one to start in anti-TNF failure cases. Now, being in India, we know that many of our patients have financial constraints, and they may have to stop anti-TNF after some time. So this beautiful study by Vineet Ahuja sir's group from AIIMS looked at what happens to these patients who stop treatment that is anti-TNF alpha after being on it for some time. So they studied 45 patients who had to stop it either because of financial burden or because of tubercular reactivation. 33 of these patients were in clinical remission at that time. They followed these patients up for 26 months, and they found that 45.5% of them relapsed over the next 26 months. But the good thing was that most of them responded to antibiotics, steroids, or anti-TNF agents, and only 3 required surgery. So the positive point here is that if a patient can take an anti-TNF alpha for at least 1 year and go on to remission, even if you stop it, over the next 2.5 years, only close to 45, that is less than 50% of the individuals have a reactivation. So what else can we do in our setup? So this interesting study in Lancet looked at another aspect of it. If somebody was on adalimumab for a long time and they are in stable remission, this LADI trial looked at whether you can reduce the dose of adalimumab from 2 weekly injection to 3 or 4 weekly injections. When they looked at cumulative incidence of persistent flyers, the results were not statistically significant. But what was found was that the last sentence over here, that is, when they compared the disease-related adverse events in the 2 groups, it was significantly higher in the group where the dosage was reduced. And hence, it is not recommended to reduce the dosage of adalimumab, even if the patient is in stable remission. Now, the third scenario is when a patient was on infliximab, was remaining stable, then has a secondary non-response. It could either be due to development of antibodies or due to poor tolerance, like development of infections. Now, what this REGAIN study did was that these patients were off infliximab for 6 months, and then it was restarted. And interestingly, even though these patients had a secondary failure of response to infliximab, which was the reason for stoppage of drugs, when it was resulted, more than 30% of them, close to 40% of them, responded to the treatment. 36% was the treatment response, which tells us that if there is no other option, the same drug can be restarted. So the newer molecules that I was mentioning of earlier on in the first slide was risankizumab and mirikizumab, which has some recent papers, and etrolizumab. So these are the three ones which I will be dealing with, because there were the papers were over the last few years. Risankizumab is actually the humanized, anything with a sumab is actually a humanized monoclonal antibody. So risankizumab is a humanized monoclonal antibody targeting cytokine IL-23. Now, why is it important is because this is the first of this mechanism of action to be approved in Crohn's disease, and it binds to the P19 subunit. The trials in this regard was Advance, Motivate, and Fortify trials. Advance and Motivate were induction trials, and Fortify was the maintenance trial. I'm not going to the details of it, but what was striking was that in all these trials, the results showed that compared to placebo, which had a response of close to 20%, the response in risankizumab group was 45 to 55%, which is very significant and excellent results for a molecule which has been recently introduced. The side effects were not much different. And the next molecule was mirikizumab. This is important because this paper was published, similar papers were published both in NEJM and AJG, and has been a molecule of interest in the West. It is again another P19 antibody, but I will just stop by telling the trial names. Lucent 1 trial was the induction trial, and Lucent 2 was the maintenance trial, and both of it showed a difference of close to 25% as far as maintenance response is concerned, and 15% as far as induction response is concerned. The side effects are exactly similar. So any of these molecules, if asked in the exam, you just need to know like what is the mechanism of action and the name of the trials. Rest everything can be fitted in. Now, etrolizumab is actually the brother of vedolizumab. So it is actually a humanized IgG1 monoclonal antibody. While vedolizumab targets the alpha-4 beta-7, etrolizumab targets the beta-7 subunit. So this is present in two receptors. So it can act both against E-cadherin binding as well as MADCAM binding. So it prevents mucosal injury and leukocyte migration at the same time, and hence it is likely to be more effective. So these are the list of trials which have been published, and all these trials have shown that the results are significantly good as far as ulcerative colitis is concerned. So hibiscus 1 and 2, hickory, laurel, and gardenia trials. All these trials have been conducted in ulcerative colitis. The last one was comparing it with infliximab, and it was found that the result of etrolizumab is as good as infliximab. Now coming to the small molecules in IBD. I want all of you to go through this paper, which was published in Intestinal Research 2022 Jan, which looked at the usage of azathioprine. So in this paper, which had among the authors Vinita Ahuja sir, Ajit Sood sir, and many others from India, they have given a detailed follow-up, a detailed protocol as to how to start azathioprine, how to initiate the therapy, and how to monitor the patient. So it is something worth reading. In the pre-therapy assessment before starting azathioprine, they recommend a detailed clinical history, baseline investigations which include a complete blood count, a liver function test and kidney function test, and an RBS. We have to screen for infections like hepatitis B, C, HIV, varicella, and Epstein-Barr virus. Vaccinate the patient for influenza, pneumococcal vaccine, hepatitis B, varicella, papilloma, and adenovirus, and Tdap. They advise us to check for both the TPMT and NUDT15, the only flip side being cost, and initiate the dosage based on TPMT and NUDT15 genotypes. So what if we can't do it? They recommend a dose escalation strategy. Start at a low dose and then slowly build it up. How should we follow these patients up? We should assess the treatment response every 3 months. because azathioprine acts slowly. You need to give at least 3 months for the response to happen. You have to do hemogram and liver function test at weeks 1, 2, 4, 8, and 12, and thereafter every 3 months. They recommend regarding estimation of 6-thioguanine and MMPR levels, but I don't think like it is widely available. And they recommend frequent monitoring for adverse effects, including development of malignancies at least once a year. So this is something which is very useful in our day-to-day practice, and I would recommend each and every one of you to read that article. Now, regarding the small molecules, there are an array of new molecules which have been proposed, but the ones that I will be dealing with are only filgotinib, upadacitinib, and Osanimote, because that is where the most trials are. So whenever you think of a new small molecule, these are the indications. It can be given in corticosteroid failure, a biological failure, or there is something called as a dual target therapy, DTT, which has been coming up recently, wherein you combine a biological with a small molecule, so that the mechanism of action, it targets 2 pathways, and hence the efficacy is higher. This can be tried in extraintestinal manifestations. When you want a stop-start therapy, small molecules can be tried, and they are also found to improve the stage of liver in patients who are having liver fibrosis. Tofacitinib, we all know, this was the first of the newer set of small molecule agents. It is a PanJack inhibitor, but inhibits more of JAK1 and JAK3. The trials which supported its use were the Octave 1 and 2, and Octave Sustain was the maintenance trial. Now, it is effective in failed response to conventional or anti-TNF therapy, but it is unaffected by other factors. Just a second. The adverse events, as we all know, include herpes zoster infection, dyslipidemia, sudden death from cardiovascular causes, and thromboembolism. But all these side effects were found in elderly age group when they were administered tofacitinib at a dose of 10 milligram twice a day, and that too for rheumatoid arthritis. Now, one flip side is that this cannot be used in people who have not completed their family, as it has been found to be feticidal and teratogenic. Now, this molecule, that is the upadacitinib, is something which we are all looking for, because we do not have a small molecule which is effective, or for a long time since azathioprine has come in for Crohn's disease. So these trials, that is the UXL and UXC trials, looked at the induction efficacy of induction of remission in patients with Crohn's disease, and they were given upadacitinib at a dose of 45 mg for 12 weeks. And as a continuation of this study, in the people who had a response to induction regime, they were grouped into 3 groups. One group was given upadacitinib 15 mg, the second group was given upadacitinib 30 mg, and the third group was given placebo and followed up for 1 year. Now, the results were promising. The 2 primary endpoints that were looked at was clinical remission at week 12 and endoscopic remission response at week 12 in the UXL and UXC trials, that is the induction trials. Compared to placebo, there was a significant effect for upadacitinib in all these trials, be it clinical remission, be it whatever was the primary endpoint, be it clinical remission or endoscopic response. The side effects were similar to what we get in tofacitinib. They include herpes zoster, hepatotoxicity, and neutropenia. The thrombotic events and the adverse cardiac events were not so much noticed in these trials. Is it effective for maintenance? Yes, it is. The dosage of 30 mg, it showed 48% response at 1 year, while it also showed a 40% endoscopic response at 1 year. So it showed that these studies show that upadacitinib is a promising molecule and can be the molecule which is the future of treatment in Crohn's disease. But we need more studies in this regard. Filgotinib is a second molecule which was tried for Crohn's disease. The results, this was in the Divergence 1 trial. The results were promising. Though statistically, if you look at the strength of evidence was not as strong as what we get in upadacitinib, this showed promising results, and hence it seems that the treatment of Crohn's disease will be brighter in the future. This is regarding the side effects, which I have already mentioned, so I will be skipping this slide. And the last among the small molecules is Osanimote. Now, when there is an increased inflammation, there is increased recruitment of T cells to the inflammatory site. So the interleukins or cytokines which get released stimulates the exit of lymphocytes from the lymph node, and these home at the site of mucosal injury. This is using a SPINK1 phosphate receptor. Now, what Osanimote does is that it binds to this receptor, and this receptor becomes internalized. So these T cells cannot go out of the lymph node, and hence the recruitment decreases and the injury decreases. So this is what the trials which showed benefit in this regard was the Touchstone UC trial and the True North trial. So these trials showed that Osanimote is effective, but there has been very limited data, and you require more data in this regard. It was approved in May 2021, but the use has not been catched up mostly because of the side effects, which include opportunistic infections, bradycardia, AV conduction delays, liver injury, and macular edema. Now moving over to the next part of IBD, that is looking at the complications of IBD. We all know that IBD is a pre-malignant condition, but how strong is the risk? And what is the difference between malignancy, which happens in the setting of IBD, compared to a spontaneous malignancy? This study, published by Birch et al. In American Journal of Gastroenterology, September 2022, looked at the differences between the malignancy that happened in the setting of IBD and spontaneous malignancy. It was found that in the setting of IBD, malignancy happened at a younger age. It was diagnosed as emergency. Many of these patients has an acute presentation. It was more on the right colon, and there was increased frequency of synchronous and metachronous malignancies. What was interesting to note was that though ulcerative colitis was the most common predisposing factor with a staggering difference compared to Crohn's, when there was presence of cholangitis, the difference was not so marked. So primary sclerosing cholangitis and IBD together was the commonest cause of malignancy. The next complication that you can expect in the setting of IBD is strictures, especially in the setting of Crohn's disease. So there were two trials which looked at how to treat these strictures. The first one was a Strident trial, where they used a high dose of adalimumab at a dose of 160 milligram per week for 4 weeks, and then 40 mg every 2 weeks plus thiopurine, compared to standard adalimumab monotherapy for patients who are having an inflammatory stricture. It was found that the intensive high-dose adalimumab regime did not have a statistically significant difference, and hence is not recommended. So if somebody has a stricture, what can you try? The next option is to either go for a balloon dilatation or use a stent. Which one was significant? That was looked at looked into in this study, that is a PROT-DILAT study, and it was found that among the two groups, one group of patients with Crohn's disease related stricture was given a CRE balloon dilatation, maximum 2 sittings in an interval of 15 to 30 days, compared to 20 millimeter fully covered SEMS. The endpoint was no therapeutic interventions for the next 1 year. And it was found that people who had a balloon dilatation responded better than the patient in whom a fully covered SEMS was inserted. So endoscopic balloon dilatation is more effective than fully covered SEMS for Crohn's disease strictures was the result of this study. Now we will move away a bit away from IBD. I discussed in a lot regarding IBD because that is where most of the papers were in the last 1 year. Now we are moving over to the esophageal diseases. This guideline published in American Journal of Gastroenterology 2022 April regarding Barrett's is a must read. Now, what it classically says is that you need to give significance only for Barrett's, which extends from the GE junction or the top portion of the folds for a length of more than 1 centimeter. If it is more than 1 centimeter, you have to take at least 8 endoscopic biopsies and confirm that it is not just an endoscopic Barrett's, but a histological Barrett's as well. Now, the further treatment is decided by whether this patient has a dysplasia or not. If the patient does not have a dysplasia, the surveillance should be done every 3 to 5 years. Suppose you have a long segment Barrett's, that is the Barrett's more than 3 centimeters, it should be done every 3 years. And if it's a short segment Barrett's less than 3 centimeters, it should be done every 5 years. Now, in case of low-grade dysplasia, you can discuss regarding the prognosis and advise eradication, endoscopic eradication therapy, which can be done either by radiofrequency ablation or cryotherapy or EMR. But if the patient decides against it, then you are supposed to do endoscopy every 6 months for 1 year and annually thereafter. For patients who undergo resection, either for low-grade dysplasia, high-grade dysplasia, or intramucosal carcinoma, the follow-up should be done depending on what was the initial histology. If the baseline dysplasia was only low-grade, then we are expected to do follow-up at 1 year, 3 years, and then every 2 years. But if it was high-grade dysplasia or T1A carcinoma to start with, then we are supposed to do follow-up at 3, 6, and 12 months, and thereafter annually. Now, if somebody has a T1B stage or above, then surgical referral is the advantage. But endoscopic eradication using a EMR or EST can be tried for patients who have low risk features, which is a well-differentiated malignancy, less than 2 centimeters, and no lymphovascular invasion. So this is in a nutshell regarding what is mentioned in this guideline, but I recommend that PG should all read this guideline on Barrett's. FLIP or functional luminal imaging probe was asked in the exam for 2 years back. At that time also, I remember that I had presented this, but this is still considered novel because it does not come widely into India. So this is a novel device that measures 2 things. It measures the cross-sectional area at a point in the esophagus and also measures the pressure. So it is what is called as a planimetry. It is FDA approved, and the best index which we measure in this is what is called as a distensibility index. So this is the device that is used for FLIP. You have a catheter which is passed through the nostrils. Towards the end of the catheter, there is a 10 centimeter balloon which has 16 impedance planimetry sensors spaced at 0.5 centimeters. Now, this balloon is filled with a fluid, and then the pressure and the area is measured. So this is how the balloon will look like. This is how the recordings will be. Initially, it was in this format, but in the FLIP 2 panometry, you get a picture something like this. This gives you the advantage that you can measure the difference during various swallows. What are the indications for FLIP? It can be used in achalasia for diagnosis and prognostication, as well as to diagnose or to assess the efficacy of the therapeutic modality which has been done. It can be used in GRD to tailor fundoplication, but has limited data for use as a diagnostic test. With more and more cases of eosinophilic esophagitis coming up, it helps us to identify the structure and remodeling that has happened in the esophagus. And in patients with stricture, it helps us to assess both the pharyngoesophageal junction and the diameter of the stricture, and thereby guide our endoscopic dilatation. So a very useful technique indeed. But there are certain significant limitations for this. This is costly. There is lack of expertise, and the data too is very limited. Now, we all know about the ECG guidelines in the management of achalasia. Basically, type 1 or type 2 achalasia is treated either by pneumatic dilatation, laparoscopic Hellers, or POEM. And in patients who are unfit, we go for botulinum toxin or smooth muscle relaxant, while type 3 is always treated by either a POEM or a Hellers myotomy. So, some of these patients undergo laparoscopic Hellers myotomy and they have a failure. So there has been considerable anxiety as to whether a previous surgery would make the POEM difficult or not. So this study looked at the efficacy of pneumatic dilatation, which is a commonly performed test, versus POEM for patients who had achalasia but has a recurrent or persistent disease even after a laparoscopic Hellers. So in this study, they included 90 patients who had a failure of laparoscopic Hellers, 45 underwent POEM, and 45 underwent pneumatic dilatation. The primary outcome was a NACAD score of less than 3 at the end of 1 year. And it was found that the efficacy was much more higher for the POEM group, 62.2%, compared to the pneumatic dilatation group, which was only 26.7%. Another interesting thing was that the difficulty was encountered only in 2 out of this 45 patients. So, just like POEM is catching up for a de novo diagnosis of achalasia, even in laparoscopy failed cases, probably POEM is the way forward. Now, regarding eosinophilic esophagitis. We often neglect most of the papers in eosinophilic esophagitis because we think like it is almost non-existent in India. But this interesting paper published in Indian Journal of Gastroenterology by Dr. Naresh Bhatt's group actually looked at this and found that 17 of the 73 patients whom they evaluated for eosinophilic esophagitis with high degree of suspicion were found to be true cases of eosinophilic esophagitis on biopsy. And probably it will catch up just like Crohn's, because we had the same feeling when Crohn's came to India earlier on. So probably in the coming years, we will see more and more cases of eosinophilic esophagitis. So it is good to have a look at what is happening in the field of eosinophilic esophagitis. The current treatment paradigm is basically PPI, but it should always be given in a double dose, that is twice daily usage. Swallowed steroids is the next option, and the steroids being given for this include fluticasone and budesonide. Food elimination diets, which can either be a step up versus top down. So you start with a single food elimination diet and gradually step it up to 6 or 8 food elimination diet, or you can start with a 6 food elimination diet and then come down. So that is another treatment option which is being followed. But the first drug, which is US FDA approved for the treatment of eosinophilic esophagitis, is Dupliament. Dupliament is actually a once weekly subcutaneous injection. It is a monoclonal antibody against interleukin-4 receptor alpha. So this is the main receptor which acts for eosinophil recruitment, fibroblast proliferation, epithelial mesenchymal transition. So it results in increased eosinophilic injury as well as development of strictures. Once this is blocked, the eosinophilic esophagitis seems to come down. It has other uses as well. It is useful in eczema, asthma, rhinosinusitis, and nasal polyposis. So this is how the guidelines from the West ask us to treat a patient with eosinophilic esophagitis. If the suspicion is high, go for a mid or an upper esophageal biopsy. And if it shows more than or equal to 15 eosinophils per high power field, you have to suspect eosinophilic esophagitis. The decision initially most often goes towards treatment of PPI twice daily, but somebody who is not keen to take it or resists PPI usage or has a severe disease, the options forward would be a food elimination diet, swallowed steroids, or Dupliament. I believe that sums up the management of eosinophilic esophagitis. Vonoprozan has been discussed. I have been discussing it over the last 3 years. We are still eagerly waiting for it to come up, but it often finds a place in the question papers. So vonoprozan is actually a potassium competitive acid blocker, a very promising molecule. Most of the study has come from Japan. It inhibits acid secretion by blocking the availability of potassium to hydrogen potassium ATPase. It is acid stable and hence rapidly absorbed. So the biggest advantage is that it can be taken in fasting or fed state without affecting its efficacy. It has a longer action, so only once daily dosing is required. It acts on both active and resting pumps because of its high pK. Even if the patient has a renal disease or a liver disease, no modification is required and has very few drug interactions. Moving over to the next session, that would be actually a Helicobacter pylori. There was an interesting paper published in American Journal of Gastroenterology recently by Ho et al. They looked at what antibiotic resistance has happened between 2011 and 2021 in the US. So they found that the resistance is marked when it comes to clarithromycin, metronidazole, or levofloxacin. For metronidazole, it was 32%. For clarithromycin, it was 32%. For metronidazole, it was 42%. And for levofloxacin, it was 36%. But the amoxicillin resistance, the tetracycline resistance, and rifabutin resistance was still very low. It was less than 10%. So I did a PubMed search to see whether there is any similar data available from India. I came across this paper which looked at the H. pylori resistance in South Asian countries. We have a rampant usage of antibiotics and very few antibiotic stewardship policies in our nation. So we expect a higher degree of resistance to the antibiotics which are given for H. pylori, and the results were not surprising. In South Asian countries, the resistance to metronidazole was seen to be close to 70%. Clarithromycin was close to 35%, and levofloxacin was close to 45%. So the resistance pattern was significantly higher. But what was more striking was that even though the resistance to amoxicillin and tetracycline was lesser than what was existent compared to metronidazole, clarithromycin, and levofloxacin, they still had significant resistance developing to the tune of 16% in amoxicillin and close to 10% in tetracycline. So this is a point worth pondering upon, and probably in our population, a bismuth-based regime would be the ideal regime. So what are the new therapeutic modalities which have been looked into? There are two significant studies in this regard. The first one was comparing a 14-day hybrid therapy, that is 7 days of rabiprazole plus amoxicillin, 1000 gram BD, and then followed by a non-bismuth quadruple regime for the next 7 days. So first 7 days, it is only amoxicillin plus PPI. In the next 7 days, it is non-bismuth quadruple therapy. And this was compared with a 10-day bismuth therapy. They have not given any clear explanation as to why a 10-day was compared with a 14-day hybrid therapy. But what was striking to note was that when this regime was used, the intention to treat cure rate was close to 92%, and the adverse events was only 27%. So this helps in decreasing the pill burden as well as while giving a high rate of efficacy and safety. So this is something which needs more studies and could be a possible or a promising option for treatment of H. pylori in the future. This study came from Taiwan. The next therapy was a vonoprazan amoxicillin dual therapy. And this had 3 groups. One was the bismuth quadruple therapy. The next was a vonoprazan amoxicillin dual therapy. In the VHA group, they gave amoxicillin 750 milligram 4 times a day, while in the dual VA group, they gave 1000 milligram twice a day. And both these groups had a treatment for 10 days. And they found that the results in the VHA dual therapy, that is vonoprazan plus amoxicillin 750 milligram 4 times a day, was very significant to the tune of 93%. And hence, a vonoprazan based regime is considered to be a promising option for the future. Now, is there any new investigation in the field of luminal or the region of the stomach? I came across this paper which looked at body surface gastric mapping or gastric allometry. This basically involves a series of electrodes placed in the epigastric region. It assesses two things, the electrical activity in the stomach and the propagational movements of the stomach. It is indicated for chronic nausea and vomiting syndrome, gastroparesis, and functional dyspepsia. And it is found to be better than traditional electrogastrography. So gastric allometry is somewhat like electrogastrography, but it records both the electrical activity and the spatial movement, and hence can be the investigation of choice for nausea and vomiting syndrome, gastroparesis, and functional dyspepsia in the future. This is how the instrument would look like, and the reading would look like what is given in the image below. We all know regarding the surveillance strategy for pancreatic cyst, and this interesting article published in JAMA Surgery compares the various guidelines and the recommendation by various guidelines as to how to follow up cyst, incidentally detected cysts in the pancreas. So most of it depends on the size, and most of the follow-up is using MRI. But as the cyst size goes up, EUS starts taking the front seat. So any cyst more than 3 centimeters, it is often EUS. Less than 1 centimeter is, less than 2 centimeters is often MRI, and between 2 and 3, it is either MRI or EUS. Now, what has seen is that most of these guidelines recommend how to screen a patient with pancreatic cyst, but they never recommend when to stop screening for it. So the patient can have two options. Either he can be going in for a surgery, and this guideline, this article further looks at various guideline recommendations for cyst. I'll be sending this article to the group, so I don't think like I'll be discussing it in detail right now for want of time. But this article in American College of Gastroenterology looked at when to stop screening for pancreatic cyst, which is not most often given in many of the guidelines. Now, they have classified IPMNs on the basis of their size and their growth. They consider something as very small if the size is less than 15 millimeter. 16 to 30 millimeter is considered as small. They consider something as stable if it doesn't show any growth, or if the growth is less than 2.5 millimeter per year. So a very small and stable IPMN, that is a size less than 15 millimeter and a growth less than 2.5 millimeter every year, can the screening can be stopped at the end of 5 years. If it is very small, that is less than 15 millimeter, but the size is increasing by more than 2.5 millimeter per year, then you can stop the screening at 10 years. If it is a small, that is more than 15 millimeter, be it either or stable or unstable, you have to continue screening the patient for 10 years. If it doesn't show any evidence of malignancy by 10 years, then you can stop it. So this probably is a very excellent article which tells you like when to stop screening for IPM. Then we have some miscellaneous articles, most of them being drugs. We know linaclotide, the newer molecule is the plicanatide. Both of them act on guanosine C, cyclase C receptors. Now it helps in two things. It helps in the relief of constipation by increasing the intestinal fluid secretion. It also results in decreased activation of visceral pain neurons. So it helps in relief of constipation as well as decrease of abdominal discomfort, and hence could be the ideal molecule for treatment of patients with irritable bowel syndrome, constipation type. As expected, the adverse effect is diarrhea. It is more effective than placebo for improving all IBS symptoms. You need to know about linaclotide and plicanatide. Linaclotide is a 14 amino acid synthetic peptide, which I've already mentioned. I will not be dealing with it any further. The next interesting molecule was Tinopinor. It is a potent inhibitor of sodium hydrogen exchanger, NHE3, located in the apical membrane of intestinal epithelial cells. It is given at a dose of 50 milligram BD, again for irritable bowel syndrome, constipation type. It has minimal side effects, but it does not take care of the pain. So the two new molecules which have come up for relief of IBS constipation type are linaclotide or plecantide and tinopinor. Now, the next molecule is ulxadoline. This is for the other IBS variety, that is patients with IBS diarrhea. It is recommended at a dose of 100 milligram orally. It acts on the opioid receptors mu and kappa. It is found to have a significant efficacy compared to placebo. It causes constipation, nausea, cardiac events, sphincter spasm, pancreatitis, and is contraindicated in patients with severe hepatic impairment. Teduglutide is a GLP-2 analog. It is safe and well tolerated. It is very effective in patients who are having a short bowel syndrome, and it helps us to decrease the need for parenteral nutrition. Even when continued for a long time, it is found to be safe, and it is now approved for both adult and pediatric patients with small bowel syndrome. Probiotics is a field of interest, and there are more and more molecules coming up, but I'll be discussing more about parabiotics, postbiotics, and psychobiotics, just to introduce the term to you. Paraprobiotics are, refer to inactivated organisms. So if there is a bacteria which has been inactivated and given in the form of a capsule, it is what is called as a paraprobiotic. On the other hand, if you use a metabolite of the bacteria for a therapeutic benefit, it is called as postbiotic. So paraprobiotic is an inactivated probiotic, while postbiotic is a metabolic product of a bacteria. Postbiotics comprises of substances like cell surface proteins, cell-free supernatants, cell lysates, bactericides, enzymes, and many other molecules which are short-chain fatty acids, which are all produced by the bacteria and can be used in certain situations. Psychobiotics are the bacteria which are given to provide a psychological benefit. So it acts on the mental health of the patient, and that is how the patient will be benefited. The last section of my today's topic would be on colon cancer screening. This is a very interesting article which looks at the future and current strategies for colorectal cancer screening. As we all know, the recommendation nowadays is to go for either a colonoscopy or a flexible sigmoidoscopy with stool occult blood testing. Fecal immunotesting came up. The advantage of fecal immunotesting was that this utilizes an antibody against hemoglobin rather than the Goic test. The advantage was that it requires to be tested only once. And unlike fecal occult blood testing, which needed 3 continuous day monitoring for fecal occult blood. Secondly, it was unlikely to be affected by the food products and was more specific for hemoglobin. And thirdly, it was found to have very significant sensitivity and specificity. But the disadvantage was that it was not very good in picking up advanced adenomas. It was good in picking up malignancies, but not so much for advanced adenomas. And you need to confirm it with a colonoscopy, and most often it is difficult. However, it is still recommended in the USA to conduct annual fecal immunotesting. The next important test for colorectal cancer screening is the multi-target stool DNA testing, or the FIT, fecal immunotesting plus DNA testing. The basic concept behind this is that if there is a malignancy or a pre-malignant condition in the colon, the cells are likely to be less coherent and they are likely to be expelled and passed out through the stools. So this study has 2 components. One is the fecal immunotesting for hemoglobin, and the next one is the stool testing for DNAs of malignant cells. So it looks at the KRAS mutations and identifies malignancies. The advantage is that it is much more sensitive and specific than FIT, but the disadvantage is that it is having a significant cost and not widely available. However, it is recommended every 3 years if you are following up patients with multi-target stool DNA testing. Now, the newer test which has come up for colon cancer screening is the M-Sept9 or the Septin9 screening. Now, it has found to have a significant specificity to the tune of 80 to 91.5%. It is non-inferior to one-time FIT for colorectal cancer screening, and it picks up adenomas as well, though at a lower sensitivity than multi-target stool DNA testing. The problem here is that this is still not recommended, but modifications are on to increase the sensitivity and probably something to look for in the future. So Septin9 is a colon cancer screening strategy. The last two imaging-based recommendations are colon capsule and CT colonography, both of which are mentioned as substitutes to colonoscopy and recommended every 5 years. In colon capsule is just like a small bowel capsule. It has significant sensitivity and specificity for all adenomas more than 6 millimeter. But for adenomas less than 6 millimeter, probably colonoscopy still is the best modality to go for. CT colonography, on the other hand, is something called as a virtual colonoscopy. It takes various X-ray images of the small bowel and reconstructs it into a 3D or a 4D image. It has got very good sensitivity and specificity again for adenomas more than 6 millimeter. What they do is they give a colonic preparation, pass in a small tube into the rectum and put in air, distend the colon and take multiple images, thereby looking at the colon in toto. So these are actually the tests which have come up for colon cancer. You can see the colon capsule in the right, the CT capsule. The CT capsule is actually another molecule, but it is in the very early stages. It is a self-propelled capsule which goes in, takes X-ray images and gives you a three-dimensional picture. You have an MR colonography as well. Then there is a multi-omics test which includes DNA and protein. The main ones are Freenome and CancerSeq. But again, these are all in the very early stages and we are yet to wait whether these will come up in the future or not. I would conclude by requesting all the postgraduates to read the following topics also. The role of artificial intelligence in gastroenterology is a sure short question. So you need to be prepared regarding artificial intelligence as well as the various areas where it can be used in gastroenterology. Liquid biopsy is another possible question. Who to screen and how to screen for celiac disease. Celiac disease has been in the front in the last few few months paper. So I think like this is a focus of interest. Cobitolimod is a DNA-based oligonucleotide that activates TLR receptor 9 and given as rectal enema for left-sided ulcerative colitis. And the trial in this regard was the CONDUCT trial. You also need to be thorough with the Bovino 7 guidelines. This guidelines of chronic pancreatitis published in 2021 is worth a read. Vaccination strategies in inflammatory bowel disease and de-escalation of immunomodulator and biological therapy in inflammatory bowel disease are all articles worth reading. Now, the article which I mentioned earlier is the one which I mentioned towards the last. It is a free article and tells you like how to start, how to continue, and how to stop azathioprine in inflammatory bowel disease. With that, I come to the end of my topic. Thank you all for your patient listening.
Thank you very much, dear Sojan, for that extensive and exhaustive review. Wonderful, lot of information. In fact, I have to admit that I've learned a lot of new things. Hearing certain terms like paraprobiotics and postbiotics for the first time. I'm sure it is certainly going to be quite useful for all the postgraduates. Are there any questions?
There are no questions in the chat. Jayanti ma'am, for your comments.
Dr. Sojan, excellent overview. I think probably we could never have updated in our lifetime the way you've done it. What I'm going to ask you is how should the PGs go about reading the updates towards the exam? No, can you give us a clue what they should be reading? I know sometimes in one particular exam, I saw that all the questions were from one BMC, there's a BMC journal.
Yes, ma'am.
And I found that they had taken from January to December, one topic of each that was in the basic sciences. I just have to pick up one article in the Google, and I found all the questions were from that particular journal. So I think you can just give us a clue. I mean, there were too many new names and all. Probably the students have to know it. I would really not. It's so difficult to remember names of drugs which are already on in current practice. But it's just phenomenal, how you do it. So even I should get, I was just thinking whether I should attempt this update. I think it's just impossible. The way both of you have done it, Abby as well as you. Wonderful. Can you give us a clue how they should read?
Yeah, ma'am. Actually, what I found was that when I was preparing for this, I went through some of the few question papers of the past. And what I found was that most of the questions which were being asked were articles which were published in American Journal of Gastroenterology, Lancet Gastroenterology and Pathology, something in NHG would always be asked, Indian Journal of Gastroenterology. So, so the best way to search in PubMed would be like looking for Indian authors. That is what I would do if I was the final year PG. Probably like if you get to know who your examiner is, go through all of his papers just prior to the exam, it will help you a lot. That's what I found.
What I also tell them is, all the conferences that we attend, and just take the program brochure and see that you answer all the questions in that program. Yes, that covers almost all the updates invariably.
Very true.
There will always be the state of art lecture, which will involve all these biological small molecules and all that. So I think that's the other way they can just go about it.
Yes.
Wonderful.
And when looking at a journal, it is always interesting to see what the editorial was about. If you look at the editorial, that tells you the key article in that journal. That's what I found probably promising for students to follow.
The only thing is many of the journals are not accessible. So that's the main issue. So whether to just read the abstract and get some information, that's something. And today, at least advances, no one can guess what questions are coming. It's just not practically possible. And they're making it more and more difficult at the national board level. Very difficult. Yes. Even for us examiners, we have to read the question, get the answer right, and then go to the examination counter to check the answers. Yes. So then we can understand the fate of the students. Thank you. Wonderful, wonderful. Thank you.
Thank you so much, ma'am.
Dr. Sojan, there are a couple of queries. Can you just go through those?
Yes, sir. Any example of the questions is like any important papers for FMT in IBD. When I went through the journal, I could find a few papers on FMT. One was for IBS, and it showed that the efficacy was very significant. It came from Indian Journal of Gastroenterology. I think like it was in April 2022. Over the last 1.5 years, when I scanned through other, the journals which I mentioned, FMT was given only in one paper. There was only one paper on FMT in IBD. That was for pouchitis, refractory pouchitis, and it was found to have a significant efficacy. But other than that, FMT was not a very common topic which was seen in most of the papers that I could come across. Another interesting paper in this regard is like I found that there was a paper from Ames group, if I remember correctly, which showed that the Clostridium difficile, or Ajit Sousa's group, which said that the Clostridium difficile infections are much lower in patients with IBD flyers in India, despite having a very high number of flyers. Sorry, I lost the chat box. Yeah.
The next question is to Jayanti ma'am. Are we expected to know all trials in details for exam viva? As you are a very seasoned examiner, you must be able to tell that.
They don't ask. They're all usually the common trials, like Stopart trial, very common ones.
Very common. That's what I also noticed.
Yeah, no one.
Very common and very commonly used drugs, not very rare.
Examiners themselves would not know. Yeah, they themselves would not know. And I think if you just get some flavor that, okay, these trials are going on, you don't have to remember the name. But invariably, the name will give you a clue as to what is the trial. So I think important.
I think nobody will be penalized if you don't remember the name of any particular trial.
No, they won't say. They will not say that.
Any example of postbiotics?
Yeah, I had given in that slide regarding postbiotics. So this includes small chain fatty acids, cell surface proteins, some enzymes like superoxide dismutase, there are trials going on regarding collecting the metabolite and giving it to an individual.
So technically, penicillin is a postbiotic, no?
Very true. Yes, sir. Yes, sir.
Perhaps the first postbiotic started to be used, no?
Yes, sir.
Is the
Okay.
advantage over a probiotic, conventional probiotic, conventional existing preparations in the market?
The next question is also to address to ma'am. How much recent we should know from exam date? How much?
The ideal is just get 3 years of your conferences that are taking place in the country. You know, what I do, I carry the brochure with me and I hand it over to the PGs and I say next 2 months answer all these questions. That's it. Invariably, know the state of art lecture, the advances.
Yeah, I think the general concept is that the textbooks which you read, even if it is the latest edition, would be 3 years old as per as its currency. So to fill up that gap of 3 years, okay, if you read only the textbook, then you won't be knowing the recent thing. This is to cover that part. That's all. It's not that you should read all the articles, etc., etc. But unfortunately, the recent things, sometimes the questions come as too recent, and probably experimental things also come as recent things. The next
But invariably, you'll find they're covered in conferences, no? That EndoCon will have the updates in endoscopy, the INASL will have updates in liver, the ISG Con will have updates. Invariably, the state of art lecture, guest lectures, and all cover up.
I think they should attend the PG course. That actually has mainly CME type topics only, no? So all the conferences, the first day generally will be a PG update. That they should attend from morning till evening.
Even if they don't attend, BT, even if they don't attend, the faculty which is attending can, that's what I do. I come and hand it over to the PGs because nowadays they're not getting sponsorship. Many things are happening in the conferences now. So collect the program and start answering. That's the best.
You mean to say
And
you
it's all
cover the
themed,
slides?
you know, like for example, pancreas will cover up pancreas. The liver covers up all the advances in liver. It's quite comprehensive. The conferences are comprehensive for the PGs.
Is there a current CRC surveillance recommendation in Indian scenario?
To be frank, I didn't come across any of those.
No, I also didn't come across. Actually, there is no society guideline as far as I know, because we don't have a task force on this.
There are many articles which tells that it is high time for colorectal scanning in India, some editorials as well, but
So that's why the ISG polyp is coming up. So I think from that you will get the cancer, little bit information on the cancer. So we'll get some information.
There's a comment that there is an FMT study by AIMS in IBD by KD Ahuja et al. By Kiran Joshi. Okay, please read up that article.
I think like this article, sir, this article was published in GUT 2022 December, if I remember correctly. And what they did was like they gave a multi-donor FMT plus anti-inflammatory therapy followed by only an anti-inflammatory diet, and it was found to be effective in remission. Like I'm sorry that I forgot to mention about this article. It was published in GUT 2022, if I remember correctly.
Probably an anti-inflammatory diet question may come.
Yes.
That's a fashionable thing now. Diet therapy in IBD. That could come. Okay. I think there are no further questions. I think we'll stop. Dr. Jerry, kindly please do the formal vote of thanks.
Okay. Yes.
Thursday there's a class, okay? VT Thursday there's a class, okay? 2 cases from LBK.
We have clinics on Thursday.
Thursday, yeah, from LBK and me. Yeah, 8:15.
Okay. Okay.
Okay.
Dr. Jerry, please.
On behalf of yes, ma'am.
Thanks, Dr. Sebastian. It's been
Thank you.
we've taken photographs together. Yeah.
Yeah.
On behalf of President, I will extend our sincere gratitude to sir for taking this much effort and pain for organizing all the details and presenting in a very lucid way. I also thank Binoy Sebastian sir for chairing the session. I also thank our moderators, Jayanti ma'am and Burgis Thomas sir, for moderating the session. I also thank the ISG Kerala for giving us this platform. Thank you.
For it is only 1.5 hours. For them, it is 3 months work. For more than that.
I understand.
It is worth the effort, sir. Thank you. Thank you for the
Thank you, Sojan.
Thank you, Sojan. Thank you. Bye-bye.
Bye. We will close the session.
Thank you.